My name is Sharon Rounds, and I'm Associate Dean for Clinical Affairs at the Warren Alpert Medical School. With Jack Elias, Dean of Biology and Medicine and Senior Vice President for Health Affairs, and Ashish Shah, the Dean of the Brown University School of Public Health, who could not be here today, it's my pleasure to welcome you to the Paul Levenger Decoding Disparities seminar series. This series is part of a joint effort between the medical school and the School of Public Health to focus on inequalities and health disparities that are experienced in healthcare today. Although health disparities are certainly not a new issue, we're now at a current moment in history where unprecedented public health crises and mass movements have collided to shed light on centuries of systemic racism in the United States, including in the healthcare industry. As academic healthcare leaders, we believe that we have a responsibility to build community awareness and to create a safe space for current and future healthcare professionals to discuss how disparities in race, ethnicity, culture, and economic inequalities will and may impact their chosen fields. So this lecture series is part of that effort. Our goal is that you will have a better understanding of where we need to make progress and what still needs to be learned as we work to close the gap on racial, economic, and social disparities of healthcare in America. I'd like to thank those who made the series a reality, including David Williams, Director of the Center of Health Equity Research, School of Public Health, and Carolyn Kuo, Associate Dean for Diversity in the School of Public Health, who worked alongside me to build out the series. In addition, we thank the superstar team that's worked tirelessly to bring together a superb lineup of scientific leaders on these important topics. We're very lucky to have this lecture series sponsored by the Paul Levenger Professorship in Economics of Healthcare, which is an endowment established in 1987 to honor the memory of Paul Levenger. The gift was made by his wife, the late Ruth Levenger, and their daughter, Betty Levenger Cohen, and her husband, Dr. John Cohen, a pediatrician who was in the Brown class of 1959. We're pleased that Betty and John have been regular attendees at other Levenger lectures over the years and will be joining us again during this series. It's important support like that of the Cohens that allows us to do this work. I'd like to ask the attendees, as your questions and comments come up during the talk, that you please enter your questions into the chat. For physicians who are interested in CME credits, you register through the Brown CME office. The series is being recorded for future viewing, and closed captioning is available. Now, I'd like to invite Wafiq Eldiri, Director of the Cancer Center at Brown, to introduce today's speaker, Dr. Otis Brawley, who has spent his life working to close racial, economic, and social disparities in the prevention, detection, and treatment of cancer in the United States and worldwide. Thank you. Take it away, Wafiq.
Thank you, Sharon. It's great to have Dr. Otis Brawley from Johns Hopkins with us today. Dr. Brawley is the Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. He also directs community outreach programs for underserved populations throughout Maryland as the Johns Hopkins Kimmel Cancer Center's Associate Director for Community Outreach and Engagement. Dr. Brawley earned his MD degree at the University of Chicago's Pritzker School of Medicine and completed a residency in internal medicine at University Hospitals of Cleveland, Case Western Reserve University, and a fellowship in medical oncology at the National Cancer Institute. From 2001 to 2007, Dr. Brawley was medical director of the Georgia Cancer Center for Excellence at Grady Memorial Hospital in Atlanta, and deputy director for cancer control at the Winship Cancer Institute. He served as the chief medical and scientific officer and executive vice president of the American Cancer Society from July 2007 till November 2018. I had the privilege of interacting with him as a member of the ACS Council for extramural grants and got to see firsthand some of his leadership at the ACS. Dr. Brawley has served in numerous advisory boards, including as chair of the U.S. Surgeon General's Task Force on Cancer Health Disparities, as a member of FDA's Oncologic Drug Advisory Committee, ODAC, as an advisor to the CDC, and as a consultant to CNN. He is a master of the American College of Physicians, fellow of the American Society of Clinical Oncology, and a fellow of the American College of Epidemiology. He is a member of the National Academy of Medicine. As you mentioned, Sharon, Dr. Brawley is a globally recognized expert in cancer prevention and control. He has worked to reduce overscreening of medical conditions, which has revolutionized patient treatment by increasing quality of life and reducing health disparities. His research focuses on developing cancer screening strategies and ensuring their effectiveness. He's championed efforts to decrease smoking and implement other lifestyle reduction programs, as well as to provide critical support to cancer patients and concentrate cancer control efforts in areas where they could be most effective. Dr. Brawley is a leader in academic medicine and stands up for what he believes in. He's also been through a lot in his life and career. He recently wrote a guest editorial for the Cancer Letter entitled, "I Could Have Been George Floyd Too," that has been widely appreciated by our field, and also racked up over 3 million miles with Delta Airlines, as he just told us. So it's great to have Dr. Otis Brawley here today speaking about disparities in cancer prevention and care. Thank you for being with us.
Thank you so much for having me. It is a real privilege to be here. I wish I could be there in person, but this is almost as good. I'm a medical oncologist and epidemiologist, and I work for Johns Hopkins. I do some consulting for the federal government and for Genentech. I wrote a book a few years ago that is still being sold, but I'm not here to promote the book. And my talk does have a little bit to do about the book, in that we're talking about disparities in health. Today, I'd like to talk about cancer death rates over the past 3 decades, define race and population categorization, because when we talk about disparities, we frequently talk about black-white disparities. I want to define disparities in the 21st century, where we're probably going to move further and further away from those racial categorizations, and discuss approaches to overcoming disparities. These are numbers from the Centers for Disease Control for 2019. The number of people dying of the 10 leading causes of death. I want to note this because this year, the 3rd leading cause of death is going to be coronavirus, something that we did not even know existed in the middle of January of this year. There will be nearly 300,000 deaths from coronavirus. There's already 220,000. But you'll see cancer is number 2, heart disease is number 1. Now, cardiovascular death rates have been declining, as have cancer death rates, but cardiovascular disease death rates have been declining faster. As a result, cancer will become the most common cause of death in the United States within the next 5 to 10 years. Forgive me for showing you a number of slides with data. I'm an epidemiologist, that's my excuse. In 1900, for every 100,000 Americans, 64 died of cancer. By 1991, it was 215. Since 1991, there's been a decline in age-adjusted death rate to 152, a 29% decline over 26 years. I would consider that to be evidence that we've had some positive effects. That's a good thing. The rise from 64 to 215 over the 90 years in the 20th century is still a concern, but the fact we have a 29% decline is a good thing. This is showing this decline using Office of Management and Budget defined racial and ethnic group categorizations. You can see the decline in Black Americans in light blue is the greatest decline since 1991 of any racial ethnic group. The decline in whites in orange. Native Americans have not had a decline, and this is the noisy number, noisy line going across the page here. And then you can see Hispanics and Asian Pacific Islanders. Now, I noted that these were Office of Management and Budget defined definitions, and indeed, 2 years before every census, the OMB in the White House defines what race categories are going to be used in that census, and then those categories are used in all federal documentation for the next 10 years. The OMB only recognizes two ethnicities, by the way, Hispanic and non-Hispanic. Now, these OMB definitions are sociopolitical and not biologic. According to the OMB's own definition, they actually say within the first two paragraphs, these are not based in biology, they are sociopolitical. These definitions have been rejected by the anthropologic community as being non-scientific, and it's been noted that race changes over time. Indeed, by the definitions in 1970, President Barack Obama was white. In 1980, he was Black. The 1970 definition said you should declare yourself to be the race that your mother considers herself to be. Now, there's much talk about diversity in clinical trials. A lot of that talk is political and not scientific. Indeed, the NIH Revitalization Act of 1993 calls for valid subset analysis among races and ethnicities. Subset analysis are not statistically significant by nature. Clinical trials participation should be encouraged by people of all races and ethnicities because it actually guarantees or assures a higher quality of care, not because we can do subset analysis amongst the races and learn something biological. Race is not a biological categorization. It is a socio-political construct. An area of geographic origin can be a biologic categorization, but as Ancestry.com and 23andMe and others have demonstrated, this can be incredibly complicated. You see, race is broad, area geographic origin is more specific and scientific, although still broad, and admixture complicates this dramatically. Amongst Blacks or African Americans, Blacks or Africans, I should say, there are 109 recognized regions, and indeed some of these regions are quite large and probably in the future will be subdivided even more. Here are some regions that are categorized as Black. And when we talk about admixture, I'll let you know I am actually partly some of the top 6, as well as I'm from 6 different European regions as well. And that's my ethnicity. When we talk about areas of geographic origin for European, there are 840 recognized, Asia 56, West Asia 5, America 133, Africa 109. When we look at populations, and you can categorize populations biologically, but you have to become very fine. Let's give you some examples. G6PD deficiency is more common amongst people originating in the Mediterranean, certain areas of Africa, India, and the Middle East. The most fine here, the HLA-B1502 allele, is common amongst, indeed, 20% of people who live within 100 miles east or west of the Thai-Burmese border. These people, if you give them the anesthesia drug Tegretol, if they have that allele, high likelihood they'll develop a Stevens-Johnson reaction with peeling of the hands and feet, raw mouth. It can actually even kill. 20% of people who live within 100 miles or 150 kilometers of the Thai-Burmese border carry this allele. It's people who live in that area, not people in all of Thailand, certainly not all people in Asia. Remember, Asia is or Asian is the racial categorization. Then another of my favorites, the sickle cell mutation has a prevalence among people originating in southern Greece, southern Italy, going into the Middle East, and has a higher prevalence in sub-Saharan Africa. If you talk or if you assess the original peoples of South Africa, they don't have sickle cell trait. I've just defined Black people who don't have sickle cell disease and white people who do. Again, the racial categorizations do not match up with genetic categorizations. Now, in the future, we're going to develop a number of precision medicines or tailored therapies. We're going to use a lot of 30 to 50 person phase 2 studies. And it's going to be much more important that we emphasize the genomic targets and markers of drug metabolism as opposed to racial differences amongst populations. Now, I showed you there's been an almost 30% decline in mortality, in age-adjusted mortality from 1991 to 2017, the last year that we have data. This is due to what I'll call wise early detection, especially colorectal cancer screening, breast cancer screening, and cervical cancer screening. And I say wise because there is unwise detection. Improvements in cancer treatment, of which there have been many, as well as prevention, especially tobacco control. We're going to talk about where there's room to improve all of these things. First, cancer screening can be beneficial, it can be harmful. It's often both, and we need good randomized clinical trials to look at the net benefit to the population. That is, to look at the risk-benefit ratio. And then we need to follow the good science, which is something we have had difficulty in doing in cancer screening in the United States, especially over the last 4 decades. This is a table put together by Graham Kolditz and his group at Washington University, looking at the causes of cancer. And from it, we can assess potentials for cancer prevention. 33% of all cancers are due to tobacco use still. Overweight, diet, and lack of exercise, think of it as a three-legged stool of energy balance, is responsible for 30%. Hereditary factors, 16%. Occupation, viruses, alcohol. By the way, UV and ionizing radiation, much of this is medical radiation, x-rays, CT scans, that sort of thing. Prescription drugs, reproductive factors, pollution. These are the major causes of cancer in the United States. If we were to look at Africa, 25% of cancers in Africa are actually due to viruses and infectious disease, HIV, HPV, hepatitis, exposure to aflatoxin. This is smoking in the United States. I noted 1/3 of all cancers are caused by smoking. In 1955, 55% of adult men in the United States smoked cigarettes, and this is the decline that we've had since 1955. The peak for women, adult women, was 35% of adult women in 1965, and here you can see the decline. Tobacco is still the leading cause of cancer in the United States, and cancers due to tobacco use are declining significantly, but we can still do a great deal to control tobacco-induced cancers. These are the percentages as of 2017 according to the CDC. You can see here non-Hispanic white women at 16%, non-Hispanic white men at 17%. You can see for the other racial ethnic categories. The Native American female number and the Native American male number, for that matter, can be a little misleading. If you go into the territories in Arizona and New Mexico, there is very little, almost no cigarette use, almost no tobacco use amongst Native Americans living on reservations in Arizona and New Mexico. You go into the plains, up into the Dakotas and Montana, there's quite a bit of smoking. So this is somewhat misleading. You can see the smoking rates for Asian Pacific Islanders and Hispanics. When we look at education, note the smoking rates. 4% of people with a graduate degree. Something about getting a GED degree, that there's more smoking amongst people who get GEDs than amongst high school dropouts who don't get a GED. But you can see education prevents smoking. This is current tobacco use for adults in 2013 by state. And this is an example, I think, of disparity. The red states, the dark red states, are where the smoking rates are 27% prevalences. In Utah and California, smoking prevalence is closer to 10%. When we look at cancers caused by infection, liver cancer deaths are expected to go up 50% in the near future due to the hepatitis. HPV is a huge driver increasing head and neck cancer. Energy balance, that is obesity, overweight, too many calories, and lack of exercise, is the significant cause of cancer. 2/3 of adults and 1/3 of children are overweight or obese today, and weight-related cancers are going to increase dramatically just within the next decade. With the decline in tobacco use, energy balance will become the leading cause of cancer in the United States. And this is more a United States problem than almost anywhere else in the world. Here you can see, in the United States in 1970, 15% of Americans were obese. Today, it's well over 35%, approaching 40%. And you can see in some of my favorite countries of the world what the obesity patterns have been. In most countries, it is going up, but not like in the United States. Even Canada, which shares television with us in the United States, does not have the rise that we see in the United States. When we look at obesity broken down by race, black, white, this is a special problem amongst non-Hispanic Black women, where now close to 60% are obese. And when one looks at obesity and the category that's slightly less worse, known as overweight, we're talking 75 to 80% of adult Black women being either obese or overweight. Now let's look at breast cancer. These are the estimated numbers diagnosed and dying of breast cancer amongst women, estimates by the American Cancer Society for 2019. There's been a 40% decline in age-adjusted female mortality from 1990 to 2016. A 40% decline. That's amazing. Screenings attributed to 40 to 50% of that decline, by the way. Also, when we talk about race, there are 7 states where Black-white mortality differences are no longer statistically significant. That despite this was Black-white death rates in the United States in the 1970s. Here, as we go into the 80s and 90s, as we learn how to screen and treat this disease, we increase the racial disparities amongst Blacks and whites. Indeed, the mortality disparity today, we're talking about 27 per 100,000 for Black women compared to 20 per 100,000 for white women. That disparity is greater today than it has ever been. And there was no disparity until 1981. And here you can see there is a white disparity with the other racial ethnic groups. Again, Native Americans, because they're only 1 to 1.5% of the population, there's so much noise in this number. Now, I told you a 40% decline in death rate for women in the United States since 1990. This is the death rate by state. Now, all states were basically homogeneous, starting at roughly the same point in the late 1980s, but we've had a 51% decline in Massachusetts and a 20% decline in Mississippi. Disparities in health is becoming much more state by state than black-white when you look at breast cancer. By the way, there's this incredible emphasis on women getting screened for breast cancer, but an analysis of women who died of breast cancer, and this was a mathematical analysis done by the CISNET group, showed that failure to follow accepted screening guidelines accounted for about 10% of the 50,000 or so women per year who die from breast cancer. Failure to get adequate treatment after diagnosis is 21 to 27% of breast cancer deaths. There's a tremendous amount of emphasis on getting screened, very little emphasis on getting treatment and getting appropriate treatment. Treatment is far more important to the number of lives that could be saved from breast cancer than is screening. Let's look at colon cancer. The American Cancer Society numbers for 2019 again for colorectal cancer. Colon and rectum for incidence is divided in the colonic and rectal. For death, it's merged 51,000 total deaths. Among the US population since early 1980, there's been a halving, a 50% decline in colorectal cancer deaths. About 2/3 of that is attributed to screening and early detection. Here we have the death rate from 1975 through 2015 for, this is Black women in red, white women in blue. Again, very much as in breast cancer, only until the late 1970s or early 80s do we start seeing disparities. We learn how to screen and treat for this disease, then we see disparities between blacks and whites, indicative of blacks less likely to get screening and treatment, whites more likely to get it. And here you can see the declines. And here, the disparities are actually starting to decrease. Today, we're at 15 per 100,000 for Black women versus 12 per 100,000 for white women. And here are the other three racial ethnic groups. We started at 25 per 100,000 in 1975. When we look at men for colorectal cancer, similar pattern again. In 1980, we learned how to screen and treat for this disease. The disparity for blacks starts, the decline for whites, and you can see where we are today. Now, this was a slide that we prepared when I was chief medical officer of the American Cancer Society, and we were heavily involved in work to support the Affordable Care Act. And this is, I hate survival statistics. People, so as an epidemiologist, let me tell you, people so often misquote survival statistics, I rarely use them. This is the one time you're going to see me use survival statistics. This is 60 months of survival. 0.6 is 60%, 0.8 is 80%, 0.9 is 90%. Stage 1 in red, stage 2 in blue, colorectal cancer. Insured dotted lines, insured solid lines, uninsured dotted lines. And this is just to show you, uninsured stage 1 do not do as well as insured stage 1. Uninsured stage 2 do not do as good as insured stage 2. By the way, the uninsured line is people who did not have insurance or they got Medicaid after diagnosis. These are people who did not have Medicaid or insurance for purposes of prevention of disease or early diagnosis of disease. These are people who could not have blood in their stool and say, I need to go to the doctor and have insurance for it. The insured could. The purpose of this slide is to show you insurance matters. If you're insured, you're more likely to do better. You're more likely to be alive at 5 years or 60 months. Indeed, in the United States of America, you are better off having stage 2 colorectal cancer with insurance than stage 1 colorectal cancer without insurance. You are more likely to be alive at 5 years with the more advanced disease with insurance. We did this as an argument for insurance. Now, we've talked about the 50% decline in risk of death from colorectal cancer over the last 40 years. This is the decline by state. We all started at roughly the same area, but there's been a 63% decline in Massachusetts, a 12% decline in Louisiana. Almost as bad as in Mississippi, but Louisiana won out this time. Why the declines that are dramatic up here, but the purple states, and you're going to see the purple states show up in various colors a lot. Sometimes I color them red. Now, the other thing one should know is colorectal cancer, surgery, and treatment. Quality dramatically changes around the country, and it changes by socioeconomics, the poor not having as good a surgery or as good of a pathologic processing as the non-poor. Hispanics, Blacks, and the poor have higher odds of receiving an inadequate resection, and they have inadequate examination of that resection by, or higher risk of inadequate examination by a pathologist. Inadequate staging leads some Blacks with true stage 3 disease being labeled stage 2, and actually leads to some of the talk that colorectal cancer is more aggressive in Blacks versus whites. The argument is a larger number of stage 2 Black patients relapse compared to stage 3 whites. It's actually an institutional form of racism due to economics that leads Blacks to get treated in hospitals where frequently the pathologists are overworked and don't have time to do these resections, compared to whites who are treated in hospitals that have some volume, but they're able to do a better job of analyzing the pathology. That's just an example of how we come up with a belief that something is racially different, and it's based on economics and inefficiencies of our system. So the causes of colorectal cancer disparities are differences in screening, pathology, treatment, all these things. And they differ by race, socioeconomic status, and region of residence. Let's look at lung cancer now. These are the numbers for lung cancer, broken down by men and women diagnosed, broken down by men and women dying in 2019. These are American Cancer Society estimates. When we look at lung cancer mortality rates early in the last decade, you can see these states had higher lung cancer mortality rates compared to these states. If you were to look at smoking, smoking is much higher in these states. If you look at smoking 30 years ago or 40 years ago, there was much higher in these states. Age-adjusted cancer mortality rates in Utah, 125 per 100,000, in Kentucky, 195. That's a huge disparity. Kentucky versus Utah. Now, this is heavily driven by lung cancer, as well as colon and breast cancer differences, but Kentucky is one of the highest smoking rates in the country. There's been a lot of talk about lung cancer screening. The National Lung Screening Trial is a trial that was published in 2011. It took 54,000 people at high risk for lung cancer and enrolled them to either sham chest x-rays or several yearly spiral CTs. It was done in 30 sites, 30 of the greatest hospitals in the United States. 10 years from the start, the punchline was 20% reduction in relative risk of death in those who got spiral CT compared to those who got the sham chest x-ray. And this is the study that led to people talking about lung cancer screening. I should point out, there were folks doing lung cancer screening before this was ever done. They got lucky. We have had people who tried to do neuroblastoma screening before we did a clinical trial to show that it doesn't work. We've had people who tried to do lung cancer screening with chest x-ray before we had studies to show it actually increased the death rate. It not only didn't work, it slightly increased the death rate. And then, of course, we did prostate cancer screening with PSA in this country for almost 10 years before we had a study to show that treatment of localized prostate cancer saved lives. And we started 18 years before a study to show that screening for prostate cancer saves lives. Now, in this high-risk group of people, 5.4 lives, this is unpeeling the onion. This is what a 20% reduction in relative risk of death means. 5.4 lives saved for every 2 people with a complication due to an invasive procedure, and for every 1 life lost prematurely due to a diagnostic procedure. This, when the study is done in 30 of the best hospitals in the country, and this is my disclaimer, results may differ as low-dose CT scanning is adopted in other facilities. How is this going to go down in Peoria is a real question. How will small rural hospitals do with lung cancer screening? The benefit risk ratio, 5.4 to 1, is likely to change. Now, assuming about 160,000 people die of lung cancer every year, we at the ACS did some calculations. If we screened everybody in the country who was over 55, heavy smoker, and we had the same outcomes as these 30 hospitals, we would have 8,000 to 10,000 lives saved per year. We prevent 8,000 to 10,000 deaths. By the way, in epidemiology, you do not save lives, you prevent deaths. This is true, by the way. Now, if this was done in 30 of the finest hospitals in the country, we would prevent 8,000 to 10,000 deaths and cause 1,500 to 1,800. This led 6 respected organizations to recommend informed decision-making for people who would qualify for screening. I point this out because it takes an awful lot to screen for lung cancer. Lots of institutional resources. Sometimes we need to think maybe those resources should be put into something else, like cervical cancer screening, breast cancer screening, or maybe even put into something having to do with taking care of children that has nothing to do with cancer. It may save more lives, maybe even smoking cessation. But how can we provide adequate, high-quality care to include preventative services to populations that so often don't receive it? It's one of the most important things that we can ask. We should also realize that unnecessary care interferes with institutional abilities to provide necessary care. We may waste effort with things like lung cancer, which are low yield, and pass up things that are higher yield. State by state disparities are increasing, by the way, with the Affordable Care Act, and I showed you the purple states versus the blue states. This is states that have expanded the Affordable Care Act in blue, states that haven't in, states that haven't in orange. Pardon me. Now, let's just sum up the true cost of health disparities to a cancer death. I already showed you that educated people are less likely to die of cancer. It is true that education lowers risk of death no matter what race one is in, no matter what economic status one is in. Education lowers risk of cancer death. And it's estimated about 600,000 Americans will die from cancer this year. If all Americans had the risk of cancer death of college-educated Americans, 22% would not die. That is, 1 in 5 cancer deaths would not go away if all Americans had the prevention. And keep in mind, for prevention, we have to go back to not smoking in the teen years. So we're talking about things over 40, 50, 60 years. 132,000 people would not die if everybody got the prevention, screening, diagnosis, and quality treatment of college-educated Americans. By the way, this figure works irregardless of race. Now, of that 132,000 who would not die if everybody got everything, keep in mind what this means. This is not 132,000 who would not die with the new breakthrough treatment. We already have the breakthrough. It's to give people everything that people should get in terms of prevention, screening, diagnosis, and treatment. 132,000. We estimate 80,000 of that 132,000 to be white. You see, the disparate population in the United States is majority white. And it's also driven heavily by socioeconomics. The issue of health disparities is no longer one of race. What we need to try to focus on is how we can get everybody good disease prevention, be it smoking, diet and exercise, alcohol avoidance, vaccination, getting optimal basic care to all peoples. By the way, the disparities are far greater in the South than they are in the Northeast. They're far greater in the West than they are in the Northeast. And keep in mind, population disparities always increase when there's scientific progress in medicine. You saw that in breast and colorectal cancer with Blacks and whites when we learned how to screen and treat. And this was seen in a number of things over the years. And it's going to occur as we move into an era of precision medicine and immunotherapy. And I want to point out, there are no disparities in smallpox. New preventive interventions are less likely to cause significant disparate outcome. As long as you can get people to adopt the prevention, we're going to have a tremendous problem with the adoption of a COVID vaccine, for example. People are just not going to take it because of how it's been handled to this day. This is my last two slides. I just want to say that what we need to move toward is not equality, it's equity. And equity, certain populations, be they Appalachian whites or poor Blacks in the inner city of Providence, need a little bit more to get where we all want to get to compared to other populations. So we really need to start thinking about equity instead of equality. And this is my last slide. This is the old Johns Hopkins Hospital. This is where Sir William Osler practiced medicine. And Dr. Elderi rounded this morning because Dr. Osler used to walk around under the dome and visit patients in the hospital. That's where the words rounding came from. And the young doctors who used to come work for Sir William Osler to learn medicine here at Hopkins, he gave them rooms up in the dome, and the nurses referred to them as residents. And that's why we all did residencies. So I'll stop at that point. Thank you so much. It's a pleasure to talk to you. I wish we could all be together.
Here's a question on racial disparities in screening, diagnosis, and mortality for cervical cancer in the United States.
Yeah.
Give a comment on that.
Yeah. Now, cervical cancer, we lose about 4,000 women per year from cervical cancer. And the data show us that of those 4,000, 95+% have had no screening in the 10 years prior to their diagnosis. Cervical cancer screening is something that really, really works and works well. And it's kind of ironic. Middle-class women in the United States very frequently get cervical screening every year. Most organizations recommend every 3 to 5 years, depending on what kind of cervical screening one gets. So we have a group of people get overscreened and then a group of people get underscreened. Those are the ones who die from it. Now, cervical screening is not very, very effective in women under the age of 25 because so many get HPV infection and then they cure themselves of the infection. Now, there's some question as to whether we should be screening some Black women later because there's this group of Black women in their 60s who develop cervical cancer screening. You know, we recommend that women who are 60 or 65 who have had 3 normal pap smears or 3 normal cervical cancer screening tests not continue cervical cancer screening. There's an open question about should we have that upper age cap on it. And that again is not a Black woman's thing. It's been brought up in the case of Black women. That's a socioeconomic thing. It's whatever the answer is going to be true for most poor whites as well.
Has the institution of HPV vaccination changed any any disparities in cervical cancer?
No, it's too early. Yeah, we started vaccinating for HPV about I would think it's now 10 to 12 years ago. And the women who die from cervical cancer develop cervical cancer in their 30s and die from it usually in their 40s and 50s. And so we started vaccinating girls who were in their early teens or even younger to try to prevent them from dying. The effects of the vaccine will probably be seen on mortality declines in another 20 years or so. We still need to be screening people, and we need to even screen the people who've been vaccinated. And so that's a really good question. The cervical cancer vaccine is an investment in reducing cervical cancer death rates well into the future. We know it does decrease cervical dysplasia, for example. It was actually approved by the FDA because it reduced dysplasia, and the FDA was willing to say if you reduce dysplasia, you're going to reduce cancer years later.
Are we starting to see any statistics on disparities in cancer survival or treatment in LGBTQ plus populations? And do you have any thoughts on how that can be better tracked and addressed?
Yeah, no real registry, with a few exceptions of some local registries and some hospitals in California, actually track those statistics. I can tell you that we do know that lesbian women have higher rates of breast cancer, because not having a child, not having a full-term pregnancy by the age of 30 increases risk of breast cancer. We can also tell you that the LGBTQ community, the sexual and gender minority community, smokes more often than at almost every parameter. If you look at college educated, at every parameter you can think of, there's more smoking there. And so I would anticipate there's more smoking related tumors. This is a population that we need more social study of for sure.
How can we provide adequate high quality care, including preventive care, to populations that so often don't receive it? Can you speak to non-monetary incentives, certification, licensing, et cetera, that help encourage physicians to offer quality care to patients and communities who can't pay for it?
I know a couple of medical practices here in Maryland who went bankrupt providing medical care to people who couldn't pay for it. So that's a touchy issue. I'll also tell you, it's not just getting people insurance. You have to give them insurance so that they can pay for the health care, as well as you need to give them support so they can utilize the health care. Sometimes that takes that involves navigation, or people who actually move people who are not sophisticated through the system, counseling folks on how to take their medicine. And let's back up a little bit. I really think that what we really need to invest in is getting everyone a health coach from an early age. And that health coach is supposed to coach the individual to stay well so they don't get sick. And that's something that we frequently don't focus on in the United States. By the way, my criticism of American medicine and money is we're very interested in making money treating people. Nobody's tried to figure out how to make money preventing disease.
Another question is, prevention is partly about effectively building trust in communities, including communities of color. Where would you like to see medical and public health training go to prepare a new generation of doctors and public health scientists to build trust with communities to effectively advance prevention?
Yeah, by the way, I've been using the word prevention. I'm thinking of a friend of mine who is a cancer survivor who would be reminding me right now, I should be using the phrase risk reduction. That is, that we're doing things to decrease our risk of getting cancer. Because when we say prevention, everybody who gets cancer is a failure of prevention. But if you talk about risk reduction, then it sounds a little bit better. I really think that we all need to focus more on risk reduction. We need to focus more on how to live a healthful life as opposed to how to find disease and how to treat it.
How will we ever know definitively the contribution of genetic factors in the disparities? Clearly, a lot of people are working on that, but you mentioned many confounders. How will we ever sort this out?
Well, I don't think we will ever sort it out on a population basis. We will only be able to sort it out on an individual basis. And we will know that individuals who have this mutation or that mutation or this combination of mutations are at this risk or that risk. And even amongst people who have BRCA mutations that we know are true mutations, it's only a certain percent who get breast cancer, and it's probably something environmental or an additional something in their genetics that we don't understand yet that causes those folks not to get cancer. So I really, the race thing, I think is, I think we've gone down a blind alley, and we need to think more about socioeconomics. My good friend Bill Nelson likes to say, race, self-declared race is just a disclosure of environmental influences over one's life.
There seems to be a paucity of literature on the risks and efficacy of flat microsurgical reconstructive options for people with sickle cell trait and breast cancer. How can we better advocate for research on these options?
Wow, now that's a very specialized thing. The numbers, unfortunately, are such that the number of people who have that problem are going to be so small. That's going to be very difficult to get. You might be able to find someone with private philanthropy who cares to do that, but it's going to be very difficult to get an NIH or to fund something like that, certainly an American Cancer Society or an NIH. Now, one of the things, and I had to deal with this when I was at the American Cancer Society, there are a lot of questions out there, a lot of really important, good questions, and you have to figure out which ones are most answerable and which ones have the greatest impact. And so you have to prioritize things. There's not enough money to do all the research. Dr. Alderi will tell you that the pay line for research projects right now at the NIH is somewhere around 9 to 10%. That means 9 to 10% of the good ideas that should be funded get funded.
There seems to be a paucity of data as it relates to prostate cancer disparities in Black men. Are you aware of data that looked at the impact of racial discrimination on early prostate screening in Black men?
Oh, I'm absolutely aware of that. I lived that. It was the Black urologists who decided that Blacks should be screened because we have high rates of prostate cancer and didn't want to answer the question, does screening actually work? I lived that one. That was a Black people problem. That was the Black urologists pushing prostate cancer screening and not wanting to answer a legitimate question. That's a classic example, by the way, in medicine of doctors who know better than everybody else and get very paternalistic. Those are the same people who argue that we shouldn't tell men that prostate cancer screening has a potential for harm and a potential for benefit, and the man needs to understand that and make a decision about whether he wants to be screened. That, by the way, is the current recommendation of almost every organization that makes a prostate cancer screening recommendation. But there are doctors who argue Black men have such a high risk, they definitely should be screened, irrespective of that recommendation. I'm sorry. Wafik told you I throw straight, I throw straight and I throw fast.
Okay. Any thoughts on how life science companies could assist physicians in addressing these disparities in care and also, well, risk reduction, I will say?
I have mixed emotions about life science companies and about drug companies that charge so much for their drugs, and some of the pricing. You know, in some instances they ought to make some money and they ought to make a profit when they work on things, when they develop new drugs. This is a long-winded way of saying I'm a little worried that some of these companies that have payment programs and so forth to help poor people get their drug have created interesting tax incentives for the company itself that don't really help the population as a whole. So you said, how can they? I'm telling you how they don't. Okay. There are some companies that do have worry about ethics and worry about how they can help populations and do try to do legitimate education about their disease. That being said, some of these commercials I see just drive me up the wall.
Besides supporting the ACA, are there any particular political initiatives that we should leverage our white coats to support right now to advocate for better health equity?
Well, I already said the ACA is not all of it. That only provides people with access, and only in the, only full access in the states that have expanded the ACA to include Medicaid for adults. We need other programs, navigation, for example. Transportation is a huge issue that leads to lots of disparities. And then I will admit that we in medicine need to become friendlier and more approachable. You know, some of our buildings even are not friendly and approachable. And then when you get to the doctors and nurses and so forth, I think the expansion of medicine to include nurses and nurse professionals, physician's assistants, has been a very good thing to help us become much better. I'm very interested in the expansion of palliative care because I think that makes us much more personable. There's some aspects of integrative oncology in the field of oncology. Do not call it alternative medicine. There's a difference between alternative medicine and integrative oncology. Integrative oncology still uses science. And that community is much more friendlier and approachable to patients very frequently. But we've got to figure out how to become more friendlier and better. But I get back to, we need to start figuring out how we can push risk reduction.
I think one final question on the area of risk reduction. E-cigarette use is now increasing amongst young people, and also as a means of tobacco cessation amongst older individuals. So, do you think there's enough research going on into the health effects of ENDS products?
No, this is actually an example of where I would say we have a clear need of something that would have huge impact. I do know that ENDS or e-cigarettes are very popular among young kids. I'm very concerned that they are actually a bridge toward combustible cigarettes. Young kids using e-cigarettes up in their bedroom where mom can't smell it. And then they eventually get hooked to nicotine and they start using combustibles later on in life. You are correct. There are some anecdotal studies to suggest that e-cigarettes can be used for cessation. But what are the effects of these e-cigarettes? What are the effects on the lungs? What are the effects on the immune system? There's some interesting data, by the way, that COVID, people who use e-cigarettes who get coronavirus tend to have more lung-involved disease. So I'm area we need to study more. I wish we could get rid of e-cigarettes altogether, though.
Last but not least, how can we better increase minority enrollment in clinical trials?
Yeah, well, again, I'm not a big believer. Now, the NIH says that you have to have minority enrollment in clinical trials, and you must do this subset analysis as if minority defines something in biology. I disagree with that premise. That was written by the Congressional Black Caucus and put in the law in 1993, by the way. I actually think that's somewhat racist, and it actually avoids the problem of socioeconomics. Now, that being said, I encourage people to go into clinical trials for cancer, and I encourage people to go to doctors who participate in clinical trials. I have definite data that part of the Black problem with cancer is that many Blacks don't get adequate treatment. And I have definite data to show that doctors who put 3% of their patients on clinical trials take better care of the other 97% compared to doctors who put no patients on clinical trials. Yeah. So clinical trials is a way of improving quality of care, be you on the clinical trial or just being taken care of by the doctor who participates in the clinical trials. So that's why I encourage minority inclusion in clinical trials.
This has been a really terrific opportunity to learn more. I just want to tell you that in the chat and the Q&A, there are many individuals thanking you for coming and appreciating all that you've provided for us. And I would like to say that our next Decoding Disparities will be next Monday, and it will be on disparities in children's health, and it will feature Phyllis Dennery, Patrick Vivier, and a representative from Rhode Island Kids Count. So we'll look forward to seeing everybody again then next week. And Dr. Brawley, thank you so much again. And Wafik, thank you for helping us bring Otis here to talk to us today.
Thank you.
Okay. Thanks to the audience for great questions too.